I want this session to be as interactive as possible, so we're basically, the three of us on the panel, who I'll introduce my fellow panelists in just a second, we would like to just sort of put one or two thoughts forward to you and then really open up the debate from the floor, because I'm really much more interested in hearing what you have to say than what I have to say, because it'll be better thought out and rather better expressed, I expect. The end of this session comes at 12:30 p.m. and we run more or less straight into the next session on smoking cessation. And the organisers would like to have a little bit of time for you to wander out and wander in. And so I think we will probably end up actually starting the smoking cessation session at about 12:35. But I'd like you to feel free, if you're finding this boring, to wander off, or if you've got friends who you want to come in, tweet them and tell them to come in, and we'll just have a very relaxed attitude to the session. I'm delighted to welcome my two fellow panelists today. Just a brief word about myself, because I always put myself first, obviously. My name's Peter Swinyard. I'm a full-time GP in Swindon. I'm also the chairman of the Family Doctor Association, and you'll find our stand just down there. Go and have a look. And my fellow panelists, Charles Alessi, who's the chairman of the National Association of Primary Care and of NHS Clinical Commissioners, has been a GP in Wimbledon and has done just about everything there is to do with the top level of general practice and of commissioning. And he has taken a very academic and business-like attitude to both commissioning and to general practice, and he has an international reputation in healthcare. Karen Taylor, Director of the Centre of Health Solutions and the lead author of the Deloitte report on primary care today and tomorrow, improving general practice by working differently. She's been with Deloitte since 2011 and is the research centre for a Centre for Health Solutions, it says here, but I'm sure she'll be able to tell us more about this as time goes on. So we've been asked, each of us, to provide some ideas on the three key challenges facing us in primary care over the next year or two. And so, without further ado, Charles, would you like to grab a microphone and lead
Thank
on?
you. Could the people at the back wave if they can hear me? Yeah, they can hear me. Thank you. Very quickly wanted to talk about three themes around what our greatest challenges are at the moment. I was accused already today, perhaps rightly, of being a little bit downbeat in my opening of the conference. But I think it's really important we understand where we are, and we're starting from a position where in many respects we can only get better, because the situation we have out there is not a very, very healthy one. I think the future for us is actually quite a good one if we manage some of the big challenges we have, and they are the personalization agenda. I think this is a really important issue, whereby people are understanding more around what their role is in receipt and management of their own healthcare, because we really are moving from disease managed systems to whole person systems. You know, people find it really quite disrespectful to think of themselves as the substrate for two long-term conditions, and really are starting to be more actively talking about themselves as a person. And I think that's going to start feeding into all sorts of things, including the tariffs we use, where tariffs could well be developed by the individuals and managed by us on their behalf. So it's really quite a challenging situation. But in essence, where we end up is we need to understand what personalization means and what it means to our relationship with people, and I think that's one dimension. Secondly, we need to understand what population health means, because I think that's a direction of travel as well in terms of capitated health systems. And in population health, of course, you have to be worried as much about the people you never see, because you have responsibility for them. And it's not something that any of us, certainly me as a clinician, was ever taught in medical school around the importance of thinking of the people who aren't there when you're seeing the people who are there. But this is the new world we're living in, and I think it's something we're just going to have to grasp. And thirdly, managing that transition, because it's very easy to say and it's damn difficult to deliver, especially if you're double running both of these systems together. I think we're going to see some really quite fundamental changes over the next couple of years, both to our contracts, where we move to more bespoke type situations, but also towards the landscape of healthcare, where we're going to be faced with a whole rash of reconfigurations and a rash of change, with us being in the center of it. So it's really managing that change personally and developing the systems we need to support each other through that. Thank you.
Well done, Charles. Thank you. Karen.
Thanks very much. I'm going to focus a bit more on the challenges for today in actually performing your roles in general practice and what you're having to do that against, the background you're having to do that against. And you all know about the reduction in amount of money going into the NHS and arguments about whether or not there is any real term growth. But the fact is that over the last 6 or so years, the amount of money going into general practice has been a lot less than has been going into the system as a whole. And yet the expectations on general practice has been that you have to see more and more patients, and the number of face-to-face consultations has gone up year on year on year, and with the latest data we have is 2010, and I'm sure if we got data today it would show an increase on that. And for certain populations, certain segments of the population, in particular the elderly, the number of consultations has increased significantly from about 5 in 2000 to over 13 now. So as you can see, that's a big challenge already. The report that we produced looked at what was the evidence for working differently. And there is a lot out there. There's a lot of individual GPs who've developed different approaches to trying to manage the increasing workload, and also to deal with the fact that the resources available in terms of the number of GPs, the increasing number of salaried GPs versus partners, the reduction in the district nurses, the ageing of that population. So finding different ways of working both within the practice and with others in community care and elsewhere. So there's lots of examples out there, but actually what you don't see is any of these good practice examples being scaled up and adopted more widely. And so what the report that I was responsible for did was just look at what was out there, identifying where there was an evidence base for something that worked well, and which enabled not just the GP practice to be more efficient and effective, but also please the patients. Because ultimately, the reason that the patients are increasing the demand on general practice is because they are increasingly needing more advice. And the third thing I'm going to come to is the use of technology. There is a whole stream on technology-assisted care. There's a whole conference at the King's Fund in a couple of weeks' time, over several days, on the use of telehealth and telecare. But actually using technology to help redesign services and to deliver things differently is really the only game in town, because without that technology assistance, you just can't do it physically. So I'd say embrace technology, look at how you can work differently with each other, but also look at the needs of your practice population and consider segmenting those needs. Patients have different needs, and if you try and not look at them holistically, it's not going to work, so you need to look at them in their various segments. Thank you.
Well done. I'd like just to put out my 3 challenges under 3 headings: internal, external and personal. The internal challenges, by that I mean the challenges within your practices, the challenge of remaining financially viable, but the very most important challenge of providing a really good personal service to your patients with continuity of care and with patients being able to identify their own doctor. We know it works, we know it reduces demand, if only slightly, in the long term, and it reduces morbidity. So that is the internal challenge, to do all of those good things while remaining financially viable, coping with the changes of QOF, coping with the changes to the DESIs and all the challenges of the CQC inspection, of being the only group in the NHS in medicine having to pay for our executioners when the CQC comes to visit. I've just paid a bill of £650 for no benefit to my patients whatever to have a CQC registration. And the external pressures, we have to develop new relationships with our clinical commissioning groups. It may be you work in a small CCG where you actually do know the guys, or you may work in a big CCG where it's just another new organisation and you don't give a damn. But you need to know them and you need to work with them because they're working in your name. There's the local area teams, there's NHS England, and wasn't that an interesting power grab when they changed from the NHS commissioning board to NHS England? That was a most interesting little bit of rebranding, and they haven't actually been very clear on how much that has cost us. And the final challenge is personal. How do you survive personally under all these pressures? More and more GPs of my generation, and I'm in my late 50s, are cracking up under the strain. They're taking early retirement. They're not able to do the full job that we signed up for in the 1980s. The job is immensely different to that I came into. And we have to recognize that if we want to be able to support our patients, we have to learn how to support ourselves and support each other. In partnerships, you have to learn to look after each other, rather better than you would in a marriage. And it's a more challenging relationship than a marriage as a partnership. Certainly, it costs every bit as much to get out of one. And you have to support your staff, because unless your staff are both good, competent and happy, your patient's experience in your practice will be substandard. And you might want to find out whether your staff are providing a really good service to your patients. How many of you here actually mystery shop your practices? I can see 3 hands go up, which is actually better than I usually get. 4, thank you. I do. I ring up. Sometimes I don't ring myself. I get a friend to ring with the phone on speaker to see what reception people get when they ring our practice. If they get the, oh God, no, we can't have an appointment, Swinyard's never here, he's always off at some blooming conference. If you get that sort of response, that's negative, and I would like to hear yes and rather than no but on the phone. Just a thought. And on that happy thought, I'm going to open up the discussion to the floor for anyone to chip in. Now, you're going to have to wave hard because I've got a spotlight right in my eyes and I can't see you. So we've got a roving mic, and please wave if you want to comment, question. Gentleman at the front here, microphone to the front, please. Thank you. At the front, third in, front row. Third in, front row. Thank you. Can everyone else wave at me, please, if they want to ask questions? Gentlemen.
I'd like to ask about, as GPs, as providers and commissioners, in which ways could we harness GPs to become providers of advanced primary care and being rather late to the table in terms of our outlook and our competitiveness? How can we become innovative and harness innovation and incubate that innovation?
Yes, Charles.
Thank you. Despite the start of the conference talking about negative things, I actually think we're in a pretty damn good place. We're in a pretty damn good place as individuals and as a profession. We're not in a good place in terms of the environment we're within, but we are in a good place because we have more confidence of a population, perhaps than other parts and segments of society have, and we also have more skills around engaging individuals. I think the challenge is in engaging populations as well as individuals, and I think that is a slightly different skill set perhaps to that which we have developed best, which is the more individual, and even the family unit is smaller than the whole population. So I think that's part of what we need to do. But I think we're in a very good place to do that because the association with local authorities and the presence of health and well-being boards is a very good place to be in. So my sense is we are there. The question is to try to understand how to best take advantage of where we are rather than just think in terms of being overwhelmed by the waves all the time, and just to dip your toe in the water in terms of engagement as well, and not to be afraid about the possibility of transparency and talking about difficult things in public, because I think we have to, because if we don't, then we will be slaughtered.
Karen.
Could I just ask what you mean, what you see as the barriers to harnessing innovation?
Yes, the primary care can be innovative. GPs can do things in a culture of close to home, perhaps with more risk, but an acceptable risk, and also cheaply. And I think at the moment GPs can't wear two hats. They can't commission themselves to provide primary care new models, and that the barrier is a conflict of interest. How do we innovate and free those primary care GPs who are interested in promoting new models without being accused of a conflict of interest?
Okay, I think I understand that. I think there are still lots of things you can do within the boundaries of the commissioner-provider split. And there are examples, as I've said, of taking technology and using it to free up your time to do other things. One of the issues is the investment, the cost of investing in technology and who's going to pay for it. But there is evidence of the cost effectiveness of some of these technologies. I would say that the things that I've seen that have freed up GPs' time the most is using things like GP triage systems. Now, when we produced the report, we had as many GPs saying, can you help us understand more about it, as we did saying that we just don't agree because of the continuity of the patient being really important. But people are making it work for different segments of the population. And I think it's understanding your population, which is what Charles was saying.
Thank you very much.
There's one here.
Here, please. We've got number 1, 2, 3 with Alan, and then 4.
Okay, I'd just like to ask Charles if you could elaborate a bit on what you think practices can do for their populations as distinct from the patients who actually contact them and are sitting in front of the GP, and whether you think there's a role for individual practices engaging with their own populations, or whether you think that it's something that you would do with local authorities or CCGs on a bigger scale.
Thank you. My sense, it's really up to both. And I wouldn't use one rather than the other, but the power of the individual practice reaching out to its patients is immense. We know that because we use that all the time in terms of that is our strength as in general practice. It's our population. But what we don't do is engage with them quite as much as perhaps we could do. You know, I remember the times when we used to talk about the need to have a patient representative on something as being something somewhat negative. And also talking about the need, and I'm old enough to be able to say that, by the way, lots of white hair. Also the need, the fact that having a patient at stymied discussion made things more difficult. I think we really need to understand the world is very different now. And we are in a place where the individuals and the populations are really going to help drive the business that we deliver. Because primary care is a business. And I think we need to remind ourselves that unless we actually have a secure source of income to be able to deliver the services, we're not going to be able to. So the message is work with the local authorities, yes, and more, but also really reach out to your population more. We have those patient groups. Let's use them more. Let's get some of the refuseniks into the tent, as well as the people we consider to be sympathetic, because that richness of the population is what we have to deal with. The quicker we learn to understand it, the better.
What we haven't heard, I mean, from that description, it sounds like the GP is like being in a bit of an isolation, or the GP practice being in isolation. And we have a wide variety of practices, from single-handed, which still exist, not very many of them left, but really big practices where they provide diagnostics, where there is a pharmacy on hand. And it's, for me, it's the collaboration and working with others that will enable you to differentiate both yourselves and work differently. And it's that partnership and working with the community health care as well as the local authorities, and not working in isolation.
Thank you. Gentleman at the front, please.
There are quite a few opinion leaders and indeed people within NHS England who suggest that English general practice is under scale. In other words, it's too small to deliver high quality health care in all its forms and also value for money. That, coupled with Charles's reasonable assertion we should be doing population health care, leads me to the question, what is the optimum size for general practice, and should it be single practice or federation model?
I'm going to grab that question first. As chairman of the Family Doctor Association, we represent by and large, smaller practices, as well as practices of any size, and our origins are in the small practices, and prior to that, Single-Handed Practices Association. The optimum size of the practice is the one that works in the area you work in for you and your patients. There isn't a true answer to that. As cost pressures come down on us harder and harder, the optimum size for the practice itself is irrelevant. What is the optimum for patients is that you have your backroom functions shared and federated with other practices, so that the cost doesn't fall entirely on yourself. Come this afternoon, listen to what I'm prattling on about if you want to, about that particular subject. It doesn't matter whether you're a small practice, single-handed, two-handed, three-handed practice. What matters is the service the patients get. What matters is the continuity of care your patients get, because that actually improves health outcomes. And I don't actually believe that the mega surgeries are the answer to life for everyone. Some patients like them, some doctors like them. I think small practices are the answer for some people. There just isn't an optimum size. And if you said the optimum size is a 10-doctor practice looking after 20,000 patients with 10 whole-time equivalent doctors, that just ain't going to work in rural Cornwall or the arse end of Cumbria. And quite honestly, it doesn't work really well even in a town where patients need a choice of going to a large practice or a small practice, because they have different atmospheres, different ethics and different ways of practicing.
Thank you. I find this really difficult because we're in an environment where more and more of resources are being taken away from primary care to assuage the very efficient shroud-waving secondary care is such a master of, and you see this with A&E repeatedly. They tend to wait for a new Secretary of State to come in on the basis that they don't. The last one wasn't there the last time they did it, and it's exactly the same thing that's happening again. So it's very difficult to see how we can scale ourselves up to a situation where we can manage population health. In terms of the size, I agree with Peter. I think there is a trade-off here. It's very easy to think in terms of efficiency and having these very large units, but what really defines the efficiency of a unit is how close those associations are between populations and individuals. And it's obviously so much more difficult to deliver that with larger rather than smaller units. I think there's something about us learning how to outsource. We haven't had a good experience of outsourcing over the years, and that's because the people who've managed the outsourcing for us in the past have managed it for their benefit rather than ours. But there is a better way of doing this, and I think there's lots of things we could share and retain our individuality.
Yes, quite. Thank you, Karen.
Nothing to add.
Okay. Question, Alan Dow at the back, please. Sorry, before Alan starts, could everyone who wants to wave at me please wave now? Right, I see 3 more questions. We will try and get them in the next 4 minutes.
Do you want to take the three?
Three at once.
Okay, we'll take 3 questions. Good suggestion. And then we'll answer them all. Then we'll shut up. Alan.
My question is quite like the last one, but not just the same. I mean, we used to think about practices in different sizes and pros and cons arguments, but some of the language that's now being used is really envisaging a response from general practice on an industrial scale, not really related to practices at all. And if I refer to covering an ever-increasing number of hours and investing in access but not meeting it with an investment of capacity and just stretching us ever thinner, that's a depersonalization service, not a personalization service. And I think I'm asking the panel, how do we actually combat those that would take us down a route that will eventually have us treating people as cans of beans and not as somebody I know, and I knew her mother and I know her daughter?
Thank you, Alan. There's someone up here who's waving. This gentleman in the front row, please.
Just want to ask a question with regards to the expanding primary care model, and in particularly for federation, which has been touched upon already. The way I see it, primary care does hold a key in that it holds the lists, and that's a key driver and a key advantage for practices if they wish to pursue an option of expanding the primary care model and bringing on and taking on more services. But what I see is a problem is that we are also faced with acute trusts who also cannot relinquish those services or many of the services in order to remain financially viable. So we're stuck in a catch-22 situation of not being able to take those services on at a risk of destabilising particularly acute services, not so much the new private providers. I'd like the panel's view on that, please.
And someone here, second person in this row, please.
It's just really the changes contractually. We understand 2013 to 2015. The debacle at the moment is NHS 111 and out of hours. And is the panel aware of when we will be taking back out of hours? And is that going to be 2014-15 or 15-16?
Thank you. Three very good questions. I'm going to take the last one first. I take 24-hour retirement in November 2015 when I hit 60. I don't mind if it's December 2015, but not in my lifetime in practice, please. We've also got the question about destabilising acute services and the very important question from Alan about how you keep the individual relationship with patients. Charles, do you want to lead on?
Okay, I'll do the three questions very quickly. I'll start with the last one, the out of hours. The answer is I don't know when it's going to come back to primary care. What I do know is there is a big political push to actually put general practice back into the name GP, back into the loop in terms of out of hours. And there are some real difficulties in doing that because clearly unless people are working 24 hours a day, it's going to be really hard to do that. We all know what the difficulty is there. I think it will happen before, but it could well not be quite as bad as it could be. I don't know yet. So I'm no wiser than you. The destabilization question, I think that's really interesting because there is a big difference with CCGs. CCGs have the responsibility to deliver the best healthcare for the population within the resources they have. They don't have the responsibility to manage the local health economy. So really the message really should be disrupt. But it's all very well to say that. The reality is all the other drivers are telling us to protect. So I think it's managing that tension, which is where we really are all the time. So I completely empathize with that. Again, no easy answer. And finally, the beans question, which I think is a really important one, around the fact that we are getting less and less resource and we being asked to do more and more and stretch resources more. I think there is a way in which we can start to think in terms of industrializing health and wellness at practice level. We're doing some work in the NAPC around that, around the Practice Innovation Network, which is around that exactly that point. It is a real challenge, but I think unless we start to grasp it, we're going to suffer. So my suggestion is we consider how we're going to do that. We're all learning how we could approach this.
On 111, I don't know the answer, but I do know that there are some areas where they're making it work. So rather than to have a wholesale change, find out why these are working. I mean, part of the problem was not evaluating the evidence before rolling it out. And so there are some which are run largely by GPs where it's working. On the acute hospital, I'm actually a non-exec in a hospital, and we're trying to reach out to our local GPs to work more closely with us, with the hospital going out into primary care and primary care coming into the hospital to try and help manage some of these populations that are the most frequent users of both services, to see how we could work better. And I don't understand why we can't overcome those silos. We talk about the silos between health and social care, but the ones within healthcare should be within our gift to be able to do something about. So look at whether you could work more closely. And there are some examples, and the one that springs to mind immediately is the London Pathway, which is for healthcare for the homeless, where the GP works within the hospital to support the hospital deliver better care for the homeless population that come into their hospital. They're now looking at trialling it for frail elderly. So there are better ways of working between primary care and the GP practice, and that's probably enough from me.
Thank you very much. I'd just like to say a little bit about your hospital question. Actually, the only way in which we're going to reduce health costs, or at least contain health costs, we have the Nicholson challenge of 20 billion. Believe me, we're going to have a 50 billion challenge in 5 years' time. And unless we look at the big eaters of health resource and actually are prepared to see some of them go to the wall, the whole NHS will go to the wall. And we have to have what the previous government used to enjoy calling constructive discomfort, where we actually challenge providers to say, where is your place in the new world and why do you justify it? And if you can't justify it, we shouldn't bow to the inevitable political pressure to preserve a hospital building. We should look at the services which patients need and receive and make sure they're provided in the best place. And we should also have a look to how this fits with training the next generation of doctors and of healthcare professionals of all types. Because one of the sadnesses to me is that junior doctors don't get the hands-on clinical experience that my generation got. And while I wouldn't want to go back to what I did with 116 or 130-hour week, which was quite honestly slave driving and was perhaps not a great learning experience, nonetheless, I and my colleagues of my generation got our hands on an awful lot of clinical experience during that time, which is very hard to mimic for junior doctors coming through. So we have to have a little bit of a tension between the learning and the service part of the health service. Because if we don't train successors for me and Charles and for other healthcare professionals in this room, when I get old and decrepit in 5 years' time, I want a good doctor to look after me. I also want a GP who I know personally, who knows me personally, and I want him or her to be able to have access to good secondary care for my care in the future. That's the tension. On that note, I'm going to thank very much my fellow panelists for their contribution. And we now are going to have a 5-minute changeover to allow the staff to move you in and out and scan you and categorize you and computerize you and generally know who you are and probably your inside leg measurement for the next talk.